She's so nice, though. She's really nice. She tries to. Yeah.
Hello, hello, hello. We've got people who are snowbound, so. And it's going to get nastier. And it is butt cold. Oh my glory, it is cold. I think I do too. Okay, she's not here. There's the other one.
My dog's probably going to My dog, he will let you laugh. They have like double what's out there.
Oh yeah, Anna lives way out. She lives on a road that never gets plowed, so.
What are we doing here? He's such a drama king. It was a very long time. I was home alone with them this weekend. My parents were in Indiana. My sisters were at okay, what are the odds are? I know, I'm scared. I don't want to drive.
No worries.
No, I can, but I'm like, if we go on a date, we're going to. That wasn't your car. It's somebody else. Yeah. And then the thing again. And my God, like, get on our bed. That's great. Now we have to worry about the else. And so,
Okay, gang. It's time to start rocking and rolling. Welcome to everyone, either online or in person. We are discussing treatments for skin ailments. We stopped last time at atopic dermatitis. Did you all get the handout I did on lice and all that? Yeah. We'll talk about those. If you do any peds or if you do any school nursing, you will run into head lice. Trust me on that one. So unfortunately, many of the products sold over the counter for head lice are not terribly effective. So that's what hopefully we'll talk about now. Well, we'll get to it. And then, okay, so acne first, then we'll go to psoriasis, and then infections and the like. Okay. Let's have a word of prayer, then let's dive in. Father, thank you for this cold day. We pray for those on the roads. Give them traveling mercy. I think about my own wife on the road who took my daughter to the airport, help her get back safely. And thank you, Rachel gets to go to a place where there's sun and no snow. And for those of us who might be ill, please lift us up, be the great physician to us. And for those of us who aren't ill, we pray you would help us to live smartly, work smartly, so that we stay healthy. And thank you for this time. We commit this time to you. We pray we'd use it wisely in Jesus' name. Amen. Very good. So, sorry? She's going to Florida. Of course, without me. She has a childhood friend. They've been friends since kindergarten. And her parents have not had a very good marriage, they put it that way. And so she kind of viewed us as second parents. So she asked me to officiate her wedding. So I officiated her wedding, and now she and her husband have gone down to Florida, and they invited Rachel to come with them. So they took Rachel's suitcase, and Rachel gets to fly down to meet them. And yeah, so when you guys become parents, something as your kids get older, you'll always be very vigilant of is their friends, because besides you, the one with the greatest influence on your kid is their friends. And so you're constantly scrutinizing their friends, and you're kind of cajoling and trying to push them into better friends sometimes, although I'm not so sure that works. When Rachel met Becca, I think it was second or third grade, Becca was such a sweet girl. We were very much over the moon that she had such a good friend, and they've stayed friends even through college and what have you. So it's just nice when stuff like that works out. So anyway, all right, enough parenting talk. Let's talk about acne. Acne is a kind of a weird condition. It's weird. Boy, is that really glary looking, or is that just me? That better? Well, now you can't write and you're going to fall asleep. So I'll tell you what. How's that? Beautiful? Can you see all right? You're going to fall asleep? Okay. So acne is very much a condition that depends upon the genetics of the individual. There have been some very carefully controlled studies on adolescent prison populations that tried to find a link between diet and either the onset or severity in acne. And those studies were very carefully designed and conducted. And those studies, even though they had lots of participants, they could find no link between diet and acne. None. Not in the severity, not in the onset. So did your parents ever tell you, don't eat, fill in the blank, make your acne worse? I don't know if it was donuts, or if it was chocolate, or if it was petting the cat, or if it was whatever. Turns out diet has very little to do with acne. Genetics seems to have more to do with acne than anything else. Now, having said that, can diet maybe be a factor given that you're going to get acne anyway? That really wasn't addressed in the study. It's possible. It's possible. I don't want to rule that out because that wasn't definitively ruled out in these studies, but genetics plays a really big role in acne. If the parents had acne, there's a good chance the kid's going to have bad acne too. So some people really don't struggle with it very much. Others struggle with it mightily. And this gets distributed throughout different people of different ethnic lineages. It doesn't matter the hue of your skin. all people at some point suffer from acne. It has to do with the severity of it. So with acne, you have you have a pore on the skin, and that pore, it's a sebaceous pore. It may or may not be associated with a hair follicle. Very often it is, but you have down in the dermis, you have a sebaceous gland, and then this sebaceous gland that when you hit puberty, hormones cause the constitution of this gland to change. So this secretes sebum. Sebum is the oil on your skin. There are waxes, there are fatty acids, there are triglycerides, and the bacteria and yeast and stuff on your skin. They use that as a food source, and you get a certain normal flora as a result of this sebum. And the sebum has mild antibacterial activities to keep other types of pathogens from colonizing the skin. Well, when you get, this has a blood supply, of course, and when you hit that glorious time in your life called puberty, hormones will change the composition of the semen, and now you have Cutibacterium, used to be called Propionibacterium, now it's been renamed Cutibacterium acnes. This one now will colonize the sebaceous pore and will plug it up, and you get a buildup essentially of material in there, and that leads to a comod, and a comod is otherwise known as a pimple or a blackhead or something like that. Well, if this gets blocked up, essentially this can go that direction, and you can now have sebaceous involvement, and that's called cystic acne. So with acne, if you treat with antibiotics, you've only solved half the problem, haven't you? You've changed the composition of these glands, or it's just going to happen again. And that's essentially what acne treatments are trying to do. You have scrubs that essentially will clean this. So for example, so here, you very clearly have cystic involvement here. This is cystic acne. This is not just a pimple or a blackhead. This is deep in the skin. This has gotten to where you're down here essentially. So topical treatments like salicylates or even benzoyl peroxide, those are cleaning agents. They clean the surface of the skin. Oh, what's that product? Oxy scrub? Is that what it's called? Yes. Say it again. OxyClean. OxyClean has the little scrubby thingies. They're called sponges, pads, whatever they're called. And they have benzoyl peroxide in them. And if you, I don't know if any of you have some or have used some, if you read I see a couple of you, yeah. If you read the ingredients, you'll find there's benzoyl peroxide. And then there might even be salicylate in there as well. Those are cleaning agents. You're trying to clean the pore, try to keep these bacteria at bay, try to get the gungus, essentially, this is supposed to be preemptive. And if you do get a commod, is to essentially clean this so that this eventually will give way to the pressure and it'll pop on its own. By the way, did you ever squeeze a pimple and pop it? No. You know why? If you put pressure on here, this bacteria now goes down into the bloodstream. You can potentially get bacteremia. Now, is that Is that a high risk sort of thing? No. Is it possible? Yeah. So you shouldn't squeeze a pimple. You should clean it, let it pop on its own. And you'll be asked that question many times. Don't squeeze pimples. Don't squeeze pimples. All right, so these products are over the counter. They're cheap. They're well tolerated. They can irritate your skin if you use them too much, but they typically do a pretty good job of cleaning the skin and taking the pimple, the zit, the commode, and getting rid of it. Well, that doesn't work, then now we look to antibiotics, topical antibiotics, essentially to get in here and kill those bacteria. You can combine these with cleaning agents often, so you can clean and kill these sorts of microbes. And you have topical clindamycin, topical erythromycin, minocycline. There's a 4% foam that's available, and that's by prescription. And when you use tetracycline drugs topically, very little is absorbed systemically. The amount of drug that gets absorbed systemically is virtually non-detectable. Consequently, usually these types of things can be used even when you're pregnant or lactating. Now, if you're taking oral tetracyclines, that is deleterious to the development of the bones and teeth of the baby. Also, tetracyclines are secreted in the breast milk. So oral tetracyclines, contraindicated during pregnancy and lactation. Topical are fine because they're not absorbed. Topical are fine because they're not absorbed. Then there's Dapsone. That's used with benzoyl peroxide. Dapsone's a little bit messy. It can discolor your skin, and if you use it, say around your eyes, it might discolor your eyelashes or eyebrows or something like that. It's temporary, it's not permanent. Then there's a stuff called azelaic acid. That's effective, comes in 20% solution. That has some anti-inflammatory capacity, so it's good for inflammatory acne, where you get those cystic areas that are just angry. They're really indurated. That's what you call stuff like that, indurated. So this is good for that sort of thing. Clindamycin comes in a generic, it's very cheap. Erythromycin is really cheap. Minocycline is a bit more pricey. Dapsone is kind of in between in terms of price. Azelaic acid is pretty cheap. That's pretty inexpensive. So if a kid comes in with acne, maybe their insurance is you've got options that are cheaper, essentially. If the topical scrubs don't work, you should go to that first. If that doesn't work, then okay, we'll go from there. All right, then we have the retinoids. The retinoids. Now, your retinoids essentially are your next line of defense, because the retinoids will change the, also tetracyclines also can change the composition of the sebaceous glands. That's one reason why, especially if they're taken orally, they're used topically, they can, albeit not as much, but tetracyclines also can change composition of the sebaceous glands. Retinoids do a good job of completely reprogramming the sebaceous gland so that its composition is now not quite so attractive to these bacteria to make this big plug, essentially, and plug the pore and cause the commode. So there's adapalene that comes in a generic. There's also a name brand. Then there's tazarotene. That's a little bit newer, but it's also in a generic. There is the tretinoin. Tretinoin is probably the one that gets used the most. That's really effective. And then tefarotene. These also come in combos with clindamycin and with benzoyl peroxide. Don't use tretinoin with benzoyl peroxide. The benzoyl peroxide will oxidize the tretinoin and destroy it. So don't combine those. If you use tretinoin, make sure you tell your patient, don't use a benzoyl peroxide scrub with that. And if your patient asks, what's benzoyl peroxide, say it's in, just have a list ready of products that he or she might buy that have benzoyl peroxide. They may even have them. And say, don't use this with the tretinoin because it'll prevent the tretinoin from working. So these will cause some dry skin. Because of the dry skin, they may cause the skin to scale a bit. They can cause photosensitivity, but that's patchy. So if you put it on your face, it'll cause photosensitivity to the face. If you put it somewhere else, but that place doesn't get exposed to the sun, then it won't be much of an issue. You can get some redness. That's not common, but it does occur. Burning and pruritus, itching, that occurs too. These are teratogenic, should not be used during pregnancy. They're also photosensitive, so you apply them at night. Apply them at night, and then they're good usually throughout the day, and then you apply them at night again. Retinoids. Yes? You put it over the acne spots usually that are, if you have areas that flare up, by using retinoids, it'll prevent them from flaring up. There is also a topical androgen receptor inhibitor. It turns out that the production of androgens by the adrenal cortex is part of the mechanism that exacerbates the change in composition of sebum. If you prevent this androgen from working on the glands, you can use that with a topical agent, and it's this agent, clascoterone. It goes by the trade name Winlevi. That patients have to be older than 12 years to go on that. It will cause usually dry skin and scaling in some patients. It's 7 to 12%, so not a lot. Some people, this is really rare, but they've been on it for a while, they may get hyperkalemia. That's not common at all. And it's usually with long-term use. That's something to keep in mind. So you might want to run some tests for potassium, just a regular blood test would reveal those potassium levels. That'd be something essentially you can try. This is essentially another option instead of retinoids. If those don't work, then you up your game. You go to oral antibiotics. So the tetracyclines are the drugs of choice, and these will change the composition of the sebaceous gland and also kill the bacteria. So you get a twofer on tetracyclines. Doxycycline, there is a name brand doxycycline. I don't know why anyone would prescribe it. The generic has been shown time and time again to be just as effective, and it's much, much cheaper. It's very inexpensive. You can get a month's supply of doxycycline for 10, 12 bucks. Not at all expensive. Minocycline. Minocycline also comes with a name brand. The generic is just as good, and it's also about 15 bucks for a month's supply. Cheap, really cheap. So these you take twice a day. There's also an extended release form. Some people with tetracyclines, their GI tract gets irritated when they take it. The extended release form tends to prevent that. So you prescribe doxycycline, start taking the doxycycline, you get a call. Oh, upchucked all day yesterday. Took this drug and can't keep any food down. Okay, I'll change your script to the extended release form. Extended release form is a bit more expensive, but it's either that or they don't keep the pill down. Yeah, extended release on that one. Minocycline might affect spermatogenesis in males. There's also a newer tetracycline called sarecycline. This, as you can see, is just taken once a day. This is new, so there's not quite as much known about this, but this drug, at least in clinical trials, is very effective. Very effective. All right, let's talk adverse effects of tetracyclines. Oral tetracyclines can cause GI disturbance, albeit you can fix that with extended release. In females, you have the risk of vaginal candidiasis because you're killing off normal flora, you're killing off lactic acid bacteria that inhabit the birth canal that will also cause the pH of the birth canal to change, and now Candida albicans and perhaps other native nasties can invade the birth canal and cause candidiasis. That's a problem in females. It's not a problem in males, obviously. There are reports of dizziness and vertigo. Those are rare, and it's not clear. That's particularly with minocycline, but it's not clear that these are linked to the drug. So people will ask you about this, but yeah, maybe not on that one. Don't use in young children. Stains teeth permanently, can interfere with bones. Don't use in pregnant women. Don't give to a lactating mother. They're secreted in the breast milk. Bioavailability of tetracyclines crashes if you take them with antacids that contain magnesium and calcium and stuff like that, or iron or multivitamins. So many people will say take them on an empty stomach. You can take them with food, but you have to make sure that you're not taking them with, say, dairy or something like that. So don't take them with yogurt or something like that. Yogurt's full of calcium. Take it on an empty stomach. Usually you take it, say, in the morning. Maybe when you get up, take it, and then take a shower and get dressed and read the newspaper and then have breakfast. And then you're fine usually. Bioavailability of oral tetracycline is very high if they're taken properly. If they're taken properly. Let me stop here. Any questions, anyone? Good, I see some of you writing furiously. All right. Oral contraceptives can also be used to treat acne. So with oral contraceptives, if you have a patient with acne and also severe menstrual cramping, you can get a twofer on this one. You don't need high dose oral contraceptives to address acne. Low dose will do just fine. And if you use a phased oral contraceptive, it'll be an effective contraceptive too. So oral contraceptives are used sometime because they will address essentially the secretion. Estrogen just changed the secretion of the sebaceous gland. That's why some young mothers will notice that their acne goes away when they get pregnant. I don't know if you've ever heard that or not. Yeah, that's the reason why. The estrogen flush from the placenta changes the composition of the sebaceous gland. This should not be your first option. This should be if other things fail, or if you want to also address contraception as well. There is also, for acne, the tretinoin. Tretinoin also comes in an oral form. And that's the one that you've probably heard of, Accutane. And usually if a young lady of reproductive age gets Accutane, gets tretinoin, oral tretinoin, she will be given birth control pills too, because oral tretinoin is extremely teratogenic, extremely. So because of that, that's usually the case. She'll be given oral birth control as well. Okay. All right, questions on any or all of this? No? All right. Then we will go now to psoriasis. While we're taking questions, you folks online, does anyone have any questions? I'll take that as a no. So we'll go on now to psoriasis. Okay, so the skin is divided into the upper epidermis and then the lower dermis and then the subcutaneous or fat layer. And the epidermis has these 5 different layers. The bottom one being the stratum basale, that's the stem cell population. That's essentially a single cell thick population. Followed by the stratum spinosum, then the stratum granulosum, the stratum lucidum, and then the stratum corneum. You can see the stratum corneum is highly layered. The cells don't have any nuclei, and they're essentially just bags of keratin, more or less. So the stratum basale, those are usually cuboidal epithelial cells. They have a high mitotic index. The whole skin gets renewed 3 to 4 weeks. The main component of dust is actually dead human skin. If you don't believe me, take some dust, gather it up, and burn it. It'll smell like burnt skin. Yeah. And then above that, you have the stratum spinosum, and these cells are starting to make vesicles that contain keratin and then other components too. Now, these cells still are attached to each other by these structures called desmosomes. And there's desmocolin and desmogliin that link them together. But you have these bound granules, and those granules give these cells kind of a little spiny kind of look to them. That's why it's called the stratum spinosum. And then above that, you have the stratum granulosum. You now essentially have these grains that contain the keratin. And this is usually a rather thin layer. Now the cells are starting to flatten, and they look kind of like checkers, kind of flat like checkers. And the cells are full of these granules. And these granules essentially are these granulohyaline granules. You also have lipids. Those lipids will be important because they're going to play a barrier role in the skin. And then above the stratum granulosum, you have the stratum lucidum. And now the cells get flatter. They're starting to dump their nuclei. And the stratum lucidum sometimes elides right into the stratum corneum, but the cells are starting to degenerate, lose their organelles, and it's called the stratum lucidum because those cells under a microscope are very clear, very clear. Then the outermost stratum corneum is completely filled with these keratin filaments. The lipid granules now have gone to the outside. You have a very water-resistant layer, and the cells essentially are constantly shed. They're cemented together by these lipids and stuff like that. Cells are very flat, and this is the protection role and barrier role of the epidermis. For example, you have burn patients. One of the biggest issues with burn patients is water loss because they're missing their epidermis because it's been burned, especially if they've been burned over large areas of the body. You really have to get fluids in them as fast as you can because dehydration is a huge issue. The other issue is thermoregulation because they don't have skin with which to thermoregulate. Good night, gang. Good night. Sleep tightly. See you tomorrow. Don't let those bed bugs bite. If they do, kill them. All right, so psoriasis. What causes psoriasis is still a big mystery. But with psoriasis, you seem to have some sort of immunologic reaction against the skin. And that causes the skin to now divide abnormally. And because it divides abnormally, the differentiation process is also hamstrung. So what causes it is not clear. There's a strong genetic component to it. That's clear. There seems to be an environmental trigger. What that trigger is, it's probably different for lots of people. Trauma, stress, dietary factors, smoking, previous infection. Regardless of how it's triggered, once it starts, it doesn't shut off. It doesn't shut off. Nelson? No, psoriasis is very rare in children. You tend to get it later in life. Some can develop it as adolescents. The earlier you develop it, it tends to be more severe. The earlier you develop it, and it tends to, the median age, I think for psoriasis, it's women, it's more common in women than it is in men. I think the median age for women is 18. I think the median age for men, I think is 23. Let me check that. I think, sorry? No. Have it for the rest of your life. Although you'll get flare-ups very often that make it worse, but there's usually a kind of baseline issue with it. So in psoriasis, you get the, man, that's annoying, isn't it? So the blood vessels will dilate at the border between the dermis and the epidermis, and the vessels will then let these immune cells into the epidermis, the big one being neutrophils, and the neutrophils will collect in the stratum corneum. There should be no neutrophils in the stratum corneum because that part of the skin is not vascularized. So that's the first sign, is the vessels will dilate and the neutrophils start to move into the skin. Let me give you a picture of this to show you what that looks like. So here we have normal skin, and if you blow this up, here's your stratum basale, stratum spinosum, stratum granulosum, stratum lucidum, just on top there, stratum corneum, and there's no neutrophils there. If you do one of these hematoxylin stains, or if you do a myeloperoxidase stain for neutrophils, they're not there. Then, if you look at psoriatic skin, first thing, what do you notice here? Same magnification. Come on, gang. What do you see? thicker. This is epidermis, gang. Look how thick that is. So your mitosis of your skin is much higher. The skin gets very thick, and then what are you noticing here? It's flaking off. It's sloughing off. And it's sloughing off prematurely. And then when you stain for myeloperoxidase activity, there are tons of neutrophils in the skin. You want neutrophils there? No, not unless there's an infection. There's no infection there. So you have nucleated keratinocytes. That's not normal. The stratum granulosum is absent. Stratum spinosum is vastly expanded. And now these cells become mitotically very active because they think inflammation is going on. Inflammation is telling the skin there's damage. We have to replace it. And this is constant. Replace, 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 replace. So it's kind of hurry up and replace, and you get this skin that's full of neutrophils and is structurally compromised. Poorly. In fact, transdermal patches, because they're not absorbing through the skin, one, the inflammation in some cases might prevent transdermal patches from allowing the drug to be absorbed. In other cases, if you have an area where you have dermis exposed, it'll absorb too fast and you'll have toxicity. So in a case like this, you really can't use transdermal medication unless you can find an area of the skin that's not subject to psoriatic lesions. That's the other thing. Psoriatic lesions will tend to form on certain parts of the skin. All right, so the inflammation causes the keratinocytes to proliferate excessively, mature abnormally, and you get the thinning essentially of the stratum basale, but the thickening of other layers and skin also whose integrity is deeply compromised. All right, so you get hyperkeratosis, as you can see here. You get sloughing of the abnormal skin, and then maturation defects, very obvious maturation defects in the skin if you do a punch biopsy. Okay, so first, the keratinocytes will produce more keratin than usual. That causes the skin to thicken. Then the keratinocytes retain their nuclei. That's called parakeratosis. And then the keratinocytes, they don't adhere to each other properly. And that causes the epidermis to fall apart. And the weakened skin makes it more susceptible to infections by bacteria, viruses, fungi. The skin has a fish scale kind of appearance. And the scales get picked off from the blood vessels in the dermis, which the dermis is rich in blood vessels, will get injured, and you get these little bleeding spots. Those are called Auschwitz spots, Auschwitz sign, an Auschwitz sign. So there's a few subtypes of psoriasis. There's so-called plaque psoriasis. You can see it here. These are little flattened areas of inflamed epidermis. They're kind of red. They're kind of salmon colored around the edges. Underneath, you have dilated blood vessels. And then you have silvery white scales on top. The plaques are usually found on the scalp. Also in areas we have high shear force, like elbows, knuckles, knees, lower back because your waistband rubs against it. That's plaque psoriasis, probably the most common, plaque psoriasis. Then you have guttate psoriasis, guttate psoriasis. These are these small spots. These are usually start in childhood. and they're triggered by an infection usually. And they're so-called inverse psoriasis. So these will be at areas where you have parts of the skin that come together and then they fold. So usually in the inguinal region or under the arms, under the breasts, elbows, like the crook of the arm, places like that. Inverse psoriasis. Pustular psoriasis. There's little pustules, red skin, full of cloudy pus. They're full of dead immune cells, and they'll form usually on the hands and the feet. And then the worst case is erythrodermic psoriasis. And in this case, you've got these scales, and you can see they're fiery red underneath, very itchy, and the skin falls off in large sheets. It's painful, yeah, very painful. Wearing clothes for these individuals is an ordeal. You give them painkillers so they can get dressed. Yes, you can. You can. That's not super common, but you can. And your psoriasis too can progress from one to the other. Psoriatic arthritis is an inflammation of the joints that goes from psoriasis from the skin to the joints. And with psoriatic arthritis, one of the signs is you get pitting of the nails. And that is almost always accompanied by psoriasis, psoriatic psoriasis. Now, psoriatic psoriasis you treat very similarly to skin-based psoriasis. So what we're going to talk about here will help. And I notice it's time for our break. So we'll go ahead and take 5, come back and talk about psoriasis. Treatment.
I'm scared that like it's not supposed to stop. I don't know if it's Sean's call or if it's a American phone. American phone really like that. I feel like it's yeah. I said, oh, I'm supposed to be phone, so I'm supposed to be early. So I feel like I don't know. I'm actually a little nervous, but mine is not too fast. Like later. And then stay later or before you come back? Not necessarily. I think it's if you can't, I think it's if like there is clinical and then technically you pick it up, if they cancel altogether. That's not fair. That would be, yeah. That would be fair though, that's not you. No, it's not. None of this is in this one.
I know, but like, they're not there, like.
I don't know what they, I don't know.
I know if I am. Here's what I have.
But I don't think they start plowing, so. Then I go look at maybe. It depends. Yeah.
When I work at Baby, when I start to walk out, I start seeing them start plowing like in here and stuff.
Oh, in here, like, I
It's
would
around
say,
5.
like back home, there's usually like a normal like DPW, like their Department of Public Works that plows. They normally have someone on call who is plowing at night in case like an emergency or something, they keep the main roads clear. But they don't focus on any side. No, anything.
That's
Yeah.
Hillsdale, that's
Because we
literally
take all
Hillsdale route.
Hillsdale
It's
is
all
all
back.
Yeah. Yeah, they don't care about that. No, so they're gonna just do all the main roads in case of like an ambulance or something. Right. Other than that, they'll wait until 5 AM for everyone else to come in. The other plow truck. How long does it only take this?
Like, if it's like clear, it's only
Like
like 35.
35, yeah, 36 minutes.
But with the snow again, we probably have to leave like.
You said 5, you said 5:15 and I was like, I hope that's enough time, is that bad? You guys are gonna have to go 30 miles an hour.
It's gonna be bad, cause it's not just gonna be you. Also, you know what I'm saying, there's the other people on the road too.
Yeah, and it's all gonna blow over the road.
Oh,
So
yeah,
no one's
it's
gonna
gonna
know
hurt.
where the road is.
It's gonna drift off.
Cause we like to play the
Yeah,
game.
it's
And it's
literally
literally
all back
Oh,
roads.
that's awful.
Yeah,
those
we know
are
we
really
like.
bad.
play the biggest number.
Yeah, for real, like last week, it wasn't
Last week.
terrible, but there's still, it's still covered like in
Yeah.
snow.
I was literally like,
I know, I'm like.
she's like, I think we're on the road.
That's awful.
And everyone in Hillsdale has pickup trucks, so they go like 60.
Yeah, and they don't. No. And then their air behind them blows you off.
Yeah.
Yeah,
I have a question.
yeah.
So I am gonna be late to class on Wednesday
Uh-huh.
because I have mass, right?
Okay.
What should I do about the quiz? Cause I'll still be here.
I can let you take it, Mrs. Schaefer. You can take it, Mrs. Schaefer,
Okay.
or you can just take it, to class. Either one. Yeah, yeah, no problem. Okay, it is time to resume. So corticosteroids, topical corticosteroids can be very effective for some people. Topical corticosteroids, they don't tend to have a lot of absorption if they're put over small areas of the body. If you use really high potency corticosteroids, you can get adrenal suppression if they're applied to large areas. Mild to moderate potency corticosteroids are safe during pregnancy and in breastfeeding women. So this is really your first line, are your topical corticosteroids. If you've been on steroids for a while, you don't really want, yeah. Yeah, pretty much. It tends to, as you get older, your chances of developing it definitely go down. But during your younger years, yeah, it can happen to anybody. Yes,
And you said it's not one of those things where like, the underlying cause and fix it.
yeah, no. You have it for the rest of your life. So yeah. So the other types of drugs are vitamin D analogs. Vitamin D analogs. And so this is one, this is calcipotriene, and this is about as effective as corticosteroids. It is inactivated by the sun, so you can't put this on and then go into the sun. It's generally well tolerated. Some people experience burning and itching when they apply it. That's not that common. It's usually fairly well tolerated. There's also a calcipotriene methimethasone combination. Comes as a generic and also in a couple of trade brands. The generic version is pretty inexpensive. This stuff in general is really not that expensive. So that's another option if you don't want to use corticosteroids. Then there's calcitriol. This is the actual active form of vitamin D. And it causes less skin irritation than calcipotriene. You may get some itching, some redness. Those tend to be mild. Some people experience some discomfort, maybe some tingling, something like that. There's just no data on pregnancy while using this. So granted, it's vitamin D. You wouldn't expect vitamin D to be dangerous to the baby, but because of that, you err on the side of caution. There's just no data. You don't use it if your patient's pregnant. Tazarotene is a retinoid, and tazarotene is used for acne. This is an acetylenic version of that retinoid. So this is a retinoid. You can use it, and then the treatment actually persists for about a month after you use it. You have an increased risk of sunburn if you use this, burning, itching, peeling, some redness, and it's a retinoid, so it's teratogenic. You don't use it in pregnant women. If you combine this with a steroid, you can drop the dose of both of them. It has increased effectiveness. It also has increased tolerability. Unfortunately, this combo is expensive. But that is a very good option, provided they have the insurance to pay for it. Then, just like with atopic dermatitis, you have your topical calcineurin inhibitors. These are not FDA approved for psoriasis, but people have used them and they're effective, so they're used off-label. You may get some, so there's topical tacrolimus and picrolimus. Picrolimus is Elidol. Extended use seems to increase the risk of lymphoma and cutaneous malignancies. That's extended use, not short-term use. Some burning, some itching, some redness. Picrolimus is definitely less than with tacrolimus. If that doesn't work, now you have to pull out the big guns. So we're going to go to oral drugs, and we're going to use oral drugs that suppress the immune system. Now, what are your risks if you suppress the immune system? You can get sick. What else? Cancer. Your cancer risk goes up too, because it's clear the immune system is undergoing, your body, the immune system is surveilling. your body for cells that don't look right. And this is one of the reasons why older laboratory animals and older people tend to get tumors, because the immune system's efficacy goes down. You also have more genetic damage as an older person. And so more of those tumors are going to escape immune surveillance. So methotrexate is an immunosuppressant. It's given orally. It can also be given by intramuscular injection or subcutaneous. You give this once a week. Low doses are well tolerated. Higher doses, basically all the tissues that depend on dividing cells are going to take a beating. So stomatitis, because the stomach is regenerating. Because of stomatitis, you'll have loss of appetite, nausea, vomiting, abdominal cramps, fatigue. You get increased liver enzymes, indicative of some liver damage. You may also have liver fibrosis, and hepatotoxicity is the most serious side effect. This drug is contraindicated in alcoholics. It's also contraindicated in people with other types of liver disease, non-alcoholic fatty liver disease, that sort of thing. Yeah. Oh, yes, you would. So LFAs before, LFAs during, and LFAs after. Do you know what I mean by LFAs? Liver function assays. Liver function test, the liver panel, the box, liver panel box, you check on the blood. Okay, some of you know what I'm talking about. Others of you are looking at me as if to say, okay, hepatic function, yeah, fine. LFAs, liver function assays. That's what they call them in the lab on the sheet. I have no idea what they call them on the sheet because I don't have a lot of familiarity with medical paperwork. Why should I? I don't fill it out all day like you guys will. Liver function test. The liver panel. You can get some bone marrow disruption, so you can get some anemia, low whites, leukopenia, thrombocytopenia, low platelets. Not uncommon, but it does happen. What are you going to do? Check those. What tests are you going to run? CBC. So, CBC, liver panel. Before, during, after. Do not give if the patient has an active infection or if the patient has an active tumor, has an active cancer. Now, they might be receiving methotrexate because methotrexate is used in several different cancer cocktails, in which case you might get a twofer on that one, treat the psoriasis and the cancer. But if they have another active tumor, you get a methotrexate, it may make the tumor a lot worse. You'll need to consult the oncologist for that one. Here's a package. It's not an expensive drug. It's very inexpensive. That's one of the advantages of methotrexate. Oh, because methotrexate is a folate analog, patients should supplement their diet with folate on methotrexate. Methotrexate is teratogenic and abortifacient. You don't let a pregnant woman anywhere near this drug. It's detected in breast milk, so it's contraindicated in breastfeeding women. Men who take methotrexate should wait 3 months before they try to make a baby. Women should wait 6 months before they try to get pregnant. And then you've got some DDIs. So proton pump inhibitors, drugs that decrease renal function, like your nonsteroidal anti-inflammatories, they will increase the serum concentrations of methotrexate and increase potential side effects. This is not a drug you want to screw around with. It's effective, but it's got its caveats. All right. We cool on methotrexate? Yes? Cyclosporin. So we looked at cyclosporin for the eye, for stasis, for dry eye. That is very safe. There's very little, if any, systemic absorption. This is oral cyclosporin. You give low doses of cyclosporin. It's generally safe, but nephrotoxicity is a worry, so is hypertension. So now, what are you going to check? Kidney function. And keep that blood pressure cuff nearby, because they should have a home monitor. They should check it, and they should check it often. And you see use of this drug for a year, more than a year is not recommended. That's why. It increases the risk of malignancies, causes GI disturbances, increased risk of infection. Hirsutism, anyone know what that is? Hair growth. Hair growth in places you may not want it to grow. Like on a woman's chin. Not good. Not good. Skin itching, headache, paresthesias, numbness, pins and needles, elevated lipid panels, and then both musculoskeletal and or joint pain, increases the risk of malignancies. I say for pregnancy, but you get an association with low birth weight and premature delivery. So many OBs I've talked to have said, no, I don't care what the FDA says, no. It is secreted in the breast milk, contraindicated in breastfeeding women. This drug is an oral retinoid, acetretin. This drug can cause a lot of damage to mucous membranes. So you can get stomatitis of the mouth. You get nasal issues. You get hair loss and dry skin and desquamation. 30-some odd % of patients will show increased liver functions. Some suggest the recommended dose is too high. And you had better not use this drug with alcohol. If you do, you are now a candidate for a liver transplant. The Apremilast. The Apremilast is a inhibitor of phosphodiesterase isozyme 4. To which you're saying, oh, joy, oh, rapture, that just really makes my day. If you increase the concentration of cyclic AMP inside immune cells, inflammation goes down. The exact mechanism is not completely clear, but PDE4 degrades cyclic AMP. If you prevent cyclic AMP degradation, you quell inflammation. That's what this drug does. The drug may cause some side effects early on, like upper respiratory infection type symptoms and headache, diarrhea. These tend to go away though. They tend to go away. If you're prone to depression, your risk goes up. Weight loss has also been reported with this drug. It's a 3A4 substrate. So if you use it with a 3A4 inducer or a 3A4 inhibitor, you might be asking for trouble. No data on pregnancy. Causes birth defects in animals. It's not detected in animal breast milk. Nothing's known about human breast milk. So just don't go there. Yeah. Repeat what it does. It increases cyclic AMP concentrations in immune cells. When that happens, they calm down. It's almost as though you give the temper tantrum child a cookie and the child calms down, so to speak. This is a newish drug, so it's expensive. There's a lot of hope that more people will take it and there'll be more data on it. There's really not quite as much data on it as people would like. What if all that fails? What are your options then? You go to a biologic. So these biologics will target molecules, cytokines that are known to play a role in promoting psoriasis. So they include tumor necrosis factor alpha, they include interleukin 23, they include interleukin 17, and drugs like that. So before you put a patient on a biologic, you must test them for tuberculosis. Because when you put them on a biologic, their risk for severe disseminated tuberculosis goes up. So you want to make sure they don't have tuberculosis in the first place. Because if you put them on it, they're going to get disseminated tuberculosis and they're going to be in deep weeds. So you test them for tuberculosis first. Always. All right. TNF inhibitors include etanercept. This is the cheapest of this group. It's also the least effective. Infliximab, which is also one of the older drugs of this group. Adalimumab, that's Humira, which is a well-tolerated drug, good drug. And then the newest drug of this bunch is certolizumab. And certolizumab is a drug that is about as effective as adalimumab. These drugs are safe during pregnancy. They do pass the placenta, although etanercept does not, but they don't harm the baby in any way. They're very effective, especially if you combine them with low-dose methotrexate. They're expensive. You're not going to get these to someone with no insurance because they're really expensive. Can be risky at times, but some folks, they have a new lease on life with these drugs. These drugs come in pens and they inject themselves subcutaneously. So if a patient has never given themselves a sub-Q shot before, you're going to have to train them how to do it. What if they say, I don't like needles? What do you tell them? One of two things: tough, get used to it, or you can hire a nurse to do it. There are nurses who will go to people's houses and give them shots, and my understanding is that there are some insurances that'll pay for that. That's at least what my sources in the insurance field tell me. Yes. Yeah, some people who are prone, for example, there's a group of people who are prone to upper respiratory infections and they tend to get pneumonia really easily. Those people, if they get on a biologic, their pneumonias are going to be more often and they're going to be more severe. Usually. That's why in some cases it's risky. The provider is really going to need to go through the patient's profile, and sometimes the risk just might be too high. You just might need to say, not for you, sorry. We have to shut this door because it's just not. This is not a drug where you say, oh, let's try this. You have to make sure everything else has failed and you have to be a good candidate for the drug. And you're the one who sees the patient. The doctor's going to look at the chart, but the doctor's going to ask you. Because you're the one who's with the patient. I'll say, maybe the patient's coming in and they're just, so on and so forth, and they're miserable. They can't sleep. They can't wear certain clothes. They can't go out in public because their psoriasis embarrasses them so much. And they've tried this, they tried that, and then they're still just, so on and so forth. And so, the provider will definitely ask your opinion. Allison?
How often do they have to?
Once a month. Once a month, usually. Yeah. All right, so you have an increased risk of malignancies. Capital letters with exclamation points, that means it's important. You don't use in patients with recent malignancies. You have increased risk of serious infection. So if you have a patient on this, they come to you, they have an infection, you take that infection with a good deal of seriousness. Some people have seen exacerbations or even new onset of cytopenias and exacerbations of heart failure, demyelinating diseases. This is uncommon, and it's not completely clear if the drugs are linked to this causally. You can get antibodies made against the drugs. In some cases, there's a lupus-like syndrome that can ensue. As soon as you stop giving the drug, the lupus-like syndrome goes away. The efficacy of the drugs is normally not affected by the antibodies, albeit in a few cases it is. Ustekinumab is a monoclonal antibody against a common subunit for interleukin 12 and interleukin 23. So this is the P40 subunit of these two cytokines, and ustekinumab, trade name Stelara, will bind to P40 and prevent the activity of both of these pro-inflammatory cytokines. Side effects include upper respiratory tract type symptoms, headache, serious infections, increased risk of malignancy. There have been long-term evaluations of those, and those long-term evaluations tended to show that those infections and malignancies weren't really all that different between the placebo group and the ustekinumab group. So this particular drug seems to be quite safe. And it comes again in an injector pen that you self-inject subcutaneously. Then you have drugs that inhibit interleukin 17, which plays a very important role in psoriasis. So these drugs tend to be very, very effective, even more effective than both ustekinumab and the TNF inhibitors. So this includes secukinumab. I think this is Costenix. Costenix, I think. In the gym, I was on the whatever, and I saw a commercial, and it said Costenix, and then the little letters secukinumab, and I said, "Oh yeah, I know what drug that is. It's a interleukin 17 antagonist." The other one is ustekinumab, and then brodalumab. With these, you have an increased risk of mucocutaneous candidiasis. You do have an increased risk of serious infections and onset and exacerbations of both Crohn's disease and ulcerative colitis have been reported. They're not common, and it's not clear that these drugs are linked to that. Antibodies against these drugs, if you take these, you'll get antibodies against them. They decrease the efficacy of izokizumab and brodalumab, but not secukinumab. Then you have a set of drugs that inhibit the P19 subunit of interleukin 23. So this is specific to interleukin 23, whereas ustekinumab hit both the subunit that was common to interleukin 12 and interleukin 23. This one hits the subunit just common to interleukin 23. All right, so this has guselkumab, tildrakizumab, and risankizumab. Yeah, I apologize for the names of these drugs. By the way, if you say MAB at the end of a drug, that means monoclonal antibody. That's why they all end in MAB. MAB. MAB, that MAB, if the drug ends in MAB, MAB, that means they are a monoclonal antibody. We talked last semester about hybridomas, how you make those with hybridomas. I will leave that to you to review and refresh your memory. All right, so with these, you can get HSV infections and tinea, fungal infections. Gastroenteritis has been reported, not hugely common, and it doesn't seem to linger. Hypersensitivity reactions have been reported, and in some patients, deep fungal infections have occurred as well. Yeah, IL-23 antagonist. There's no adequate data on pregnancy and the IL-17 inhibitors. So, but that one, nobody knows, the err on the side of caution. There's no data also on ustekinumab. So ustekinumab also no real data, and no real data on the IL-23 inhibitors either. So those as well are just kind of, yeah. All of these are subcutaneously injected. You don't need to keep going to the doctor to get these injected. The drug companies have made it so you buy these pens, and some of the pens are single use. So that's a single use pen there. For example, you inject it, you pitch it. Others are pens that you can reuse for several months, so you don't have to keep pulling pens out and so on and so forth. These drugs are not cheap. Need to emphasize that. Twenty-four weeks worth of ustekinumab is $22,000. Yeah. Oh my gosh. 24 weeks worth. So that's 6 months. That's half a year. Is 22 grand. Isakizumab, 24 weeks worth is 32,000. Secukinumab, 24 weeks worth is 31,000. Infliximab, 24 weeks worth is 9,000. Right bit cheaper. Yeah. Yeah. But the insurance company won't pay for this unless they're convinced you tried everything else and it didn't work. Yeah. Yeah, exactly. Exactly. So generic methotrexate, $1,750. So you can see why methotrexate's used. Okay, please take out your handout for the head lice and all that. So head lice infestation occurs in all age groups. It's not just in elementary school. It's probably more pronounced in elementary school, but you can get head lice outbreaks in high schools, and there have even been some in colleges. So head lice, and it doesn't mean if someone gets head lice that they're from a low socioeconomic status. You can get kids who go to school with other kids and they get head lice, and it may have nothing to do with socioeconomic status or even hygiene. It's just the fact that you had contact from one head to another head. And when kids play with each other, they do a lot of head-to-head contact, roughhousing and all that and what have you. So the first set of agents that can be used to treat them are the pyrethroids. So these come from chrysanthemums. They're a natural extract of chrysanthemums. They're used in many household insecticide sprays. You have a combination usually of the piperonyl butoxide. Resistance to this product is present in the US. The rates of resistance vary from one place to another. In Michigan, last I checked, which was last month, there's not a lot of resistance to pyrethrin in head lice in Michigan. So you can use this product. The issue with this product is short-lived, no residual effects. You have to keep reapplying. It's unstable in heat and light, and some people have allergies to it. Doesn't kill all the unhatched eggs, so its ability to kill eggs is limited. So this is Rid that you can buy, heck, at Meijer or Walmart or whatever. Heck, you can probably even buy it at Weatherwax down the street. Permethrin is this stuff that's called Nix. Unfortunately, a lot of head lice strains are resistant to this in the US. So Nix is kind of given the Nix. It's not recommended because of pretty high resistance to it. And it tells you how to apply it. You shampoo the hair, you dry it, then you rinse and blah, 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 so on and so forth. You do get an itchy scalp with permethrin. Those are the two over-the-counter products, and they're not great. Some people can use them, particularly if their head lice infestation is light, and they're fine. Do you guys know how to check for head lice? How do you check for head lice? There you go. Pulling the hair, strand by strand. The eggs can be hard to see. You want the light essentially to be indirect. The eggs will be easier to see that way because the eggs are small. And if some nurses will actually wear little magnifying bits on their glasses, if they wear glasses, or they'll wear magnifiers, and that will help them see the eggs and the animals a lot better. As you pull the strands apart, you'll see the little boogers scurrying for cover, and they're pretty hard to miss. The rest of the compounds you have to get by prescription. Malathion. Malathion you apply to dry hair, you brush it in, and you keep it on the hair for the day. It's very effective. Malathion is very safe. The problem with malathion is that it's an organic solvent. Don't use a curling iron or blow dryer on your hair. It might ignite. That's bad. Can we agree? Yeah. So the other thing about malathion, it doesn't smell too nice. So malathion, not everybody's favorite, but it's very effective. And yeah. Malathion is a liquid. You work it into the hair with your hands. Usually you wear gloves because you don't want to get the little beasties on your bone. You work it in, and then so usually in the morning, you put it on in the morning, they have it on during the day, and then you shampoo it off at night. If it needs to be reapplied, you'll tend to want to reapply it a week later. Most people usually one treatment's all they need. Malathion is cheap. Malathion, literally you could drink it and it doesn't hurt you. It's very safe. Very safe. It's also safe during pregnancy. So if you have a mom who's pregnant and she's working on a kid, no danger to her baby. None. All right, we'll finish this. Then we'll talk about antibiotics on skin, and then that'll help us circle back to the antibiotics. All right. Have a good night, gang. I will see you all later.